Hello everyone, Assalamu alaikum. This is Dr. Khair and today we are going to discuss spinal cord syndromes. So let's get started. These are the syndromes that we are going to discuss today that includes poliomyelitis, which is a viral infection, affect mainly the anterior horn cell of the spinal cord, spinal muscular atrophy, which is a genetic condition, and amyotrophic lateral sclerosis, tabes dorsalis, subacute combined degeneration, anterior spinal artery occlusion that cause anterior spinal cord syndrome. So the spinal cord syndromes result from localized injury or dysfunction of specific tracts of the spinal cord. We will discuss the tracts in the next slide. We will discuss the anatomy of the spinal cord, and the common causes include trauma, vascular injury and compromise, tumors, infections like poliomyelitis, and even metabolic causes like vitamin B12 deficiency. So this is a cross-section of the spinal cord. On the right side, all of these are ascending tracts, and on the left side are descending tracts by the red color. We divide the spinal cord into anterior segment, which is all of this, and posterior segment, which is only this. We call this dorsal column, right side here and left side here. The dorsal column is formed from two major tracts, the cuneate facialis for upper limb and gracilis fasciculus for lower limb. For cuneate, I say it like cuneate, there is letter U for upper limb, and the gracilis, there is letter L for lower limb. Okay, so you can't forget it. So this is the dorsal column, and when it ascends to the brain and decussate at the level of the medulla, it forms the medial lemniscus. Okay, so this is the dorsal column that forms medial lemniscus, which is responsible for proprioception, fine touch, fine pressure, vibration, and stereognosis as well. Here is the spinocerebellar tract. We have posterior spinocerebellar tract here and anterior and or ventral spinocerebellar tract here. This is responsible for proprioception as well, and it's injured at a condition called subacute combined degeneration. Okay, here is the lateral spinothalamic tract. We have two spinothalamic tracts. One is lateral and one is anterior or ventral. The lateral one is responsible for pain and temperature sensation, and the ventral one is responsible for pressure and crude touch sensation. Remember that we said that fasciculus, gracilis, and cuneate, which is dorsal column, is responsible for fine touch, but ventral spinothalamic tract is responsible for crude touch. Okay, we finished the ascending tracts. Now let's move to the descending tracts. We have very important tract called corticospinal tract. We have also lateral one of it and ventral one of it here. The lateral one is responsible for limb movement, voluntary, and the ventral part is responsible for axial movement. Okay, we have as well extrapyramidal tracts. All of these four are extrapyramidal tracts that is responsible for coordination of the movement and flexes and postural movement. That include rhombospinal tract, lateral reticulospinal tract, vestibulospinal tract, and pectospinal tract. We don't need to remember all of this. You don't need to remember the sites of these tracts. Just what you need to know is that we have the corticospinal tract that is responsible for voluntary movement. It's divided into lateral and ventral parts. You need to know the dorsal column and its function, fasciculus, gracilis, and cuneate. You need to know the spinothalamic tract that's responsible for pain and temperature sensation. We need to know as well the spinocerebellar tract that's responsible for proprioception as well. So these are the major things you need to know. Okay, corticospinal tract, dorsal column, and spinothalamic tract, spinocerebellar tract. And I will simplify it at the next slide. Fasciculus gracilis is responsible for what? Is responsible for proprioception, fine touch, fine pressure, vibration, stereognosis, but for lower limb. Fasciculus cuneate for upper limb. Okay, here is the lateral corticospinal tract. We divide it as well into four parts like this. This is for cervical region, and here is the thoracic region, this is lumbar region, and this is the sacral region. So I say sacral is lateral. To remember it, sacral is lateral here at corticospinal tract. Anterior horn of the spinal cord, this is anterior horn and this is the posterior horn. The anterior horn is responsible for the motor function as well, but at its level. Okay, so we say in Arabic, gray matter, at its level, okay? The gray matter, if it's dysfunctioned, it will cause lower motor neuron symptom. Why we say upper motor neuron lesion and lower motor neuron lesion? The point is, if the lesion is above the tracts here, like tracts are descending right here, if the lesion is above, like at this level, it will cause upper motor neuron lesion. But if the lesion is below it, like at anterior horn cell, specifically if a peripheral nerves, it will cause lower motor neuron lesion, okay? Now we have corticospinal tract, spinothalamic tract, pain and temperature sensation, anterior corticospinal tract, which is responsible for axial movement, voluntary as well. Here is a white, anterior white commissure. What is the function of this area? This area is very important because the spinothalamic tract versus any other tract decussate at its level. So the right spinothalamic tract will decussate here to supply the left part of the body, and left spinothalamic tract here will pass through the anterior white commissure to supply the right side of the body. So if this area is injured, like condition central cord syndrome or syringomyelia, it will cause loss of pain and temperature sensation in cap-like distribution, okay, at both upper limb. Nice, because it injured the spinothalamic tract, okay? So let's dive into the major part of this lecture. First spinal cord syndrome we are going to talk about is poliomyelitis. And poliomyelitis is actually caused by viral infection called the poliovirus. It affected the anterior horn cell. But the very important part is that it's asymmetric lesion versus spinal muscular atrophy that we will going to discuss it later. Spinal muscular atrophy causes symmetric dysfunction of both anterior horn cell, but poliomyelitis causes asymmetric lesion and dysfunction of the anterior horn cell. So poliomyelitis is a poliovirus transmitted fecal-oral route like infected food or water, replicate in oropharynx and the small intestine, then spread via blood to CNS. So first the virus is present at intestine, then he spread via blood to the spinal cord and CNS. It affected the anterior horn cell of the spinal cord. That caused lower motor neuron lesion. Why lower motor neuron lesion? Because, as we said, the lesion is at gray matter or peripheral nerves. Any lesion at this level will cause lower motor neuron lesion. Any lesion above this level or at white matter, it will cause upper motor neuron lesion. What is the symptom of lower motor neuron lesion? It will be flaccidity, atony, and weakness. Versus upper motor neuron lesion, it will be spasticity and increased reflexes. It will cause acute lower motor neuron sign, acute because it's a viral infection, and asymmetric, both by letter A, okay, anterior horn cell, fecal-oral for poliovirus, fasciculation, viral meningitis, symptoms because it's a viral infection, it can spread to the meninges. Respiratory involvement may cause respiratory failure, of course. CSF, we will find the leukocyte bleocytosis. Because it's a viral infection, the lymphocyte will be high. Versus bacterial infection, we will see the neutrophils, that will be high. The proteins will be high, but it will be slightly high. The glucose level will be normal. Virus can be isolated from stool or throat swab. Now, spinal muscular atrophy versus poliomyelitis, it causes symmetric spinal cord lesion, like here. And the spinal muscular atrophy is congenital degeneration of the anterior horns, okay? So it's a congenital condition of the anterior horns due to autosomal recessive mutation of SMN1 gene defective in SNRNP ribonucleoprotein assembly lower motor neuron apoptosis. Okay, the most important thing is that it is symmetric lesion and the gene that's fucking here is SMN1 gene. Okay, the most common type of spinal muscular atrophy is a type 1 spinal muscular atrophy, which is called Werding-Hoffmann disease. The other name for this condition is floppy baby syndrome. You will find the baby is floppy. When you raise it, you will find their hands are flaccid and it cannot make a straight posture. Okay, so this is spinal muscular atrophy. This is similar to condition of botulism as well that cause flaccid paralysis, but botulism commonly affect the face, okay, and the ocular muscles. But spinal muscular atrophy and floppy baby syndrome, Werding-Hoffmann disease, is most common type of spinal muscular atrophy. It causes the axial skeleton as well. The clinical finding will be symmetric lower motor neuron lesion versus asymmetric floppy baby, and hypotonia because it's lower motor neuron lesion, and tongue fasciculation. And this is very important finding that you can consider it as a keyword or buzzword at your word vignettes and USMLE exams. Okay, amyotrophic lateral sclerosis affect the lateral corticospinal tract. So you will say when we affect the lateral corticospinal tract, what will happen is upper or lower motor neuron lesion. You will say it will be upper motor neuron lesion because we cause injured and affection of the white matter. Okay, so it will be upper motor neuron lesion. And anterior horn cell, which is gray matter, when it injured, it will cause lower motor neuron lesion. What? So this is very confusing clinical picture. You will find the vignette of man of age around 40 or 50 with spasticity and fasciculation at the same time. But the most important thing at this condition is that there is no sensory symptoms. If the vignette mentioned like there is bowel or bladder dysfunction, there is paresthesia, there is radiculopathy or painless or pain, if all of this or any of this is mentioned, the answer will not be amyotrophic lateral sclerosis, because the most important part that this don't include sensory symptom, no sensory symptom at this condition. And this can help you differentiate it from other conditions like multiple sclerosis that is spared in the space and spared in the time. Okay. Amyotrophic lateral sclerosis is combined upper motor neuron and lower motor neuron degeneration, lower motor neuron sign like fasciculation, flaccid weakness, atrophy, and the bulbar palsy of the palpar muscle of the face. Okay, the upper motor neuron sign will be spasticity and hyperreflexia more than 2, and clonus as well, and pseudo bulbar palsy. Okay, that's associated with emotional disturbance. There is no sensory or bowel bladder deficit, and that's an exam clue. This is very important and this is very high yield for this condition. Okay, most patients die from respiratory failure. So if the question vignette is classic for amyotrophic lateral sclerosis, and just ask about cause of death at this patient, it will be respiratory failure. What if I asked you about cause of death at Friedreich ataxia? Do you remember this? It will cause cardiomyopathy. Yes, you are right. Okay, but the cause of this at amyotrophic lateral sclerosis is respiratory failure. There is a condition that causes ascending flaccid paralysis. Do you remember it? Yes, it's Guillain-Barré syndrome, a post-infectious condition. The cause of this at it is respiratory failure as well. The treatment for this condition is riluzole, edaravone, but this agent don't eliminate the disease at all, but it's decline and slow the progression of the disease. Okay, like Alzheimer treatment as well. The third condition we have is tabes dorsalis. Tabes dorsalis is caused by bacteria from the spirochetes. It's Tribonium pallidum that causes syphilis. Okay, and we have 3 major phases of syphilis. Phase 1 that causes chancre, phase 2 that has rash and lymphadenopathy, generalized lymphadenopathy, and phase 3 that cause neurologic and cardiologic finding, and tabes dorsalis is one of the neurologic finding of phase 3. Phase 3 cause gamma as well. Okay, so the tabes dorsalis affect mainly the dorsal column. So the patient will have very important finding, positive Romberg sign. What is a positive Romberg sign? It's inability to make a puncture when the patient closes his eye. But when the patient opens his eye, it will be able to make a puncture. And this differentiate from the cerebellar and the sensory ataxia. Cerebellar ataxia, the patient will not be able to keep puncture even if he open eye, but at sensory ataxia like tabes dorsalis here, where the patient will be able to keep the puncture if he opened the eye, but when the patient closes the eye, it will not be able to keep the puncture and will be fall on the floor. So the dorsal column, as we said, is responsible for proprioception, and you feel your puncture, okay, and fine touch and fine pressure and vibration and stereognosis. All of this will be fucking at this condition. So tabes dorsalis is seen in tertiary syphilis and degeneration of dorsal column like gracilis and cuneate, and roots as well. The presentation will be impaired proprioception, so it will cause sensory ataxia and positive Romberg sign, as we said, absent deep tendon reflexes, and this is important as well. But positive Romberg sign is the most important thing and very, very high yield for this condition, and it's pass level question. It's associated with shooting pain. It will be very painful because it affects the roots. Okay, the Argyro-Benson pupil. What is the Argyro-Benson pupil? This is a condition that causes the eye don't accommodate to light, but it accommodates to near vision. So when I near something from your eye, the pupils will constrict. Okay. On the other hand, when I near the light from your eye, your pupil will constrict normally. But at Argyro-Benson pupil, the pupil will not constrict to light, but it will accommodate to near vision. Okay, this is very important thing at tabes dorsalis. There is Charcot joint as well, and this is present at advanced diabetes mellitus cases as well. The Charcot joint is briefly unawareness of the joint. You don't aware of the joint. It causes multiple injuries at this joint. It has acute and chronic forms. Okay, but this is more for step 2 CK, step 1. The fourth thing I need you to know is subacute combined degeneration. This is mainly caused by vitamin B12 deficiency, and from its name I remember the lesions and the tracts that are injured here. The spinal subacute, I say this is spinocerebellar tract. Okay, that's responsible for proprioception. The spinocerebellar tract, if you remember, we said it's a present here. We have ventral part and dorsal part. This is the posterior or dorsal part of it, and there is ventral part here as well. Okay, so this will be injured. The combined, remember me, by corticospinal tract. Okay, like this corticospinal tract, and degeneration, remember, dorsal column, medial meniscus. Okay, so this is a dorsal column. It calls bilateral lesion of the dorsal column. Okay, subacute combined degeneration due to vitamin B12 deficiency. It causes demyelination of the dorsal columns and lateral corticospinal tract and spinocerebellar tract. So when dorsal column is injured, the patient will suffer from ataxia and paresthesia and impaired vibration and position sensation. And when the corticospinal tract is injured, the patient will suffer from upper motor neuron sign. And if I asked you, what is the most common cause of vitamin B12 deficiency? The most common cause of vitamin B12 deficiency is pernicious anemia or malabsorption. Like if we have terminal ileum disease, bariatric surgery, pancreatic insufficiencies, so there is no pancreatic enzymes, or insufficient intake like vegetarian diet, or parasites like Diphyllobothrium latum. Okay, all of this causes vitamin B12 deficiency, and pernicious anemia is a megaloblastic macrocytic anemia. Okay, knowing all of this will guide you to the right answer. The last thing I want to discuss with you is the anterior cord syndrome, and this is caused by anterior spinal artery dysfunction. It's caused by trauma or aortic surgery, like abdominal aortic aneurysm surgery, and this is very high yield cause for this condition. And what will happen is that we will have dysfunction of all of the anterior spinal artery function, but the posterior spinal artery function, like dorsal column, it will be fine. Okay, so the vignette will mention that the proprioception, the fine touch, the fine pressure, the vibration, all of this are normal, but the patient has upper motor neuron lesion here due to dysfunction of the corticospinal tract. Pain and temperature sensation will be lost due to dysfunction of the spinothalamic tract, but the most important thing is the dorsal column function is normal. The proprioception, fine touch, all of this will be normal, and this is versus this is bilateral versus the posterior spinal artery, because we have only one anterior spinal artery. So when the anterior spinal artery is injured, we'll have bilateral symptom, but we have two posterior spinal arteries. So if one is injured, we will have the unilateral symptom. So this is the difference between anterior and posterior spinal artery lesions syndromes. The anterior cord syndrome spare the dorsal column and the horns. The mid-thoracic region is watershed area. Okay, so why mid-thoracic region is watershed area? Because there is an artery called artery of Adam-Quiggs. This artery provides territories to the spinal cord below the level of T8. Okay, so at the mid-thoracic area, this is watershed area, and it's the most susceptible to anterior spinal cord syndrome. The causes are aortic aneurysm repair. This is very high yield. The severe hypotension as well cause this condition. The clinical symptoms are upper motor neuron sign below the lesion, okay, and lower motor neuron sign above or at the level of the lesion, because the lower motor neuron sign is caused by dysfunction of the gray matter, جريوا عليه, تمام, but the upper motor neuron sign is caused by dysfunction of the white matter, the corticospinal tract for an example. So this will cause the upper motor neuron sign below, just below its level. Loss of pain and temperature sensation due to dysfunction of the spinothalamic tract. Vibration proprioception spare, this is very important. Okay. So the summary for all of this, we mentioned 6 conditions for spinal cord syndromes. The poliomyelitis and the spinal muscular atrophy affect the anterior horn cell. This is asymmetric and this is symmetric, but the symptom will be lower motor neuron sign only. The amyotrophic lateral sclerosis is upper and lower motor because it affects the corticospinal tract and the anterior horn cell as well. Okay. Tabes dorsalis affect the dorsal column only, so the patient will have positive Romberg sign and argyroperson pupil. The subacute combined degeneration is caused by vitamin B12 deficiency, and the dorsal column, corticospinal, spinothalamic tract, spinocerebellar tract will be affected. The anterior spinal artery occlusion, it causes motor, pain, temperature sensation, loss, but the most important thing is that it spares the vibration, sensation and proprioception and fine touch and all of this functions of the dorsal column, the medial lemniscus. So hopefully this helps you kind of put this all together. And I know this is can be complicated video, but I will go through more similar things in the future to really hit this home. We have as well the central cord syndrome, syringomyelia, posterior cord syndrome, and Brown-Séquard syndrome, which is very important. We will mention and discuss all of this at the next and upcoming videos, inshallah. And I will see you at the next one.